busy schedules, but hopefully you all find it helpful and useful. And like Casey said, we'll try to answer everyone's questions at the end of the talk. So I don't have any financial or commercial disclosures as it pertains to this talk. And so I figured, I'll talk about three of the most common conditions that I see patients come in to the office with, and hopefully shed some light as far as what they present like and how we go about treating them and get patients feeling better. So we'll start off with bunions, and then we'll move to talk a little bit about plantar fasciitis, and then we'll discuss at the end problems with regards to the Achilles tendon. So when we talk about a bunion, the word bunion actually comes from the Greek word that was used to refer to a turnip. And the reason was that oftentimes when you develop a bunion, you develop that prominence over the medial aspect of the foot. When I say medial, I mean on the inner aspect, so on the side of the foot by the big toe. And this prominence develops at the base of the big toe. And oftentimes, and hopefully you can see my cursor here, right around that purple circle, this area can become quite red from rubbing. And so that is where the Greeks thought it looked like a turnip. And so that's where the term bunion came from. The technical term that we use to describe this condition is hallux valgus, and that's actually a Latin term. Hallux is the word that is used to refer to the big toe, and valgus refers to a lateral angulation of the toe. And when I say lateral, that means towards the outside of the foot. So again, just like I said, it refers to a lateral deviation of the big toe or the hallux. And so what happens is, again, hopefully you can see my cursor, but we have the first metatarsal, which is this bone here. This is an x-ray representing someone who has a bunion. The first metatarsal starts to angle medially or in the direction of this red arrow. And then what happens is a compensatory mechanism, the proximal phalanx, or this bone that's labeled PP, starts to deviate laterally in the direction of the purple arrow. And this, right where the red arrow is where patients develop that medial eminence or that medial prominence that is oftentimes so painful. So what causes bunions? Well, we don't exactly know in every case. And I would tell you that, in my opinion, it's multifactorial, meaning that there's multiple reasons for someone to develop a bunion. One of the more common reasons is shoe wear, and in particular, high-heeled shoe wear or shoe wear that has a narrow toe box. In other words, a shoe that really crams the toes together. Studies have been done on patients with high-heeled shoe wear, and they have revealed that the pressure on the forefoot, and when we refer to the forefoot, that essentially means the part of the foot down by the toes, that the pressure on that area increases by about 70% for every inch that the heel is. So that can be a significant amount of pressure on that area of the foot if, for instance, someone's wearing a 3 or 4 inch heel. The other factor that oftentimes is implicated in the development of bunions is genetics or family history. Studies have shown that upwards of 70% of the time there is some family history of bunions. So we have our parents and our grandparents to oftentimes thank for these deformities. And then otherwise, there are various medical conditions that can contribute to the development of a bunion. Inflammatory arthritis problems such as rheumatoid arthritis can certainly predispose someone to developing a bunion, and other disorders that are maybe a little bit less common, but in which they render patients with ligamentous laxity, or their ligaments are generally very loose, that can also lead to development of bunions. So this is just an example of how shoes can really affect the shape of our foot and specifically our toes. On the left, this is a depiction of an x-ray of someone's, both of their feet when they are barefoot. So they don't have any shoes on. And you can take note that there is a little bit of angulation of the big toe, but a little bit of angulation is considered normal. Then we see that same patient on the right wearing a high-heeled pair of shoes, and you just see just how crammed in those toes become, and specifically the effect that it has on the big toe. And so you can imagine that if someone is wearing this type of shoe wear for 8 hours a day, 5 days a week for upwards of 50 weeks out of the year, the foot is eventually going to just conform to that shape. So in terms of the prevalence of bunions, it's estimated that 2 to 4% of the population has a bunion. I would argue that it's probably higher than that. It is more common in the female population. These deformities can worsen with age, but that is not always the case. Oftentimes, it does involve both sides, in which we call that a bilateral deformity, but it does not mean that both sides are equally affected in terms of the degree of the deformity. It also means that both sides are not equally affected in terms of the symptoms. I would say the majority of patients that I see who have a painful bunion, they may have a bunion on the other side, but it's generally not as severe in terms of the deformity, and it's also generally does not bother them. We see that patients who have bunions on both sides typically do have a strong family history of bunion deformities. So in terms of the symptoms, the most common symptom is pain over the medial eminence. And what I mean by the medial eminence is, again, hopefully you can see my cursor here, the prominence that develops on the inside aspect of the inner aspect of the foot, right at the base of the big toe. So that oftentimes is the area where patients have the most pain. It can also create difficulty with shoe wear. Of course, there are also cosmetic complaints just by the looks of the deformity. And we can get deformities also as a result of the bunion involving the lesser toes. And when I say lesser toes, that essentially means every toe except for the big toe. So the second, third, fourth, and fifth toes. And what happens, as you can see in this picture, the big toe will start to deviate further and further towards the second, third, fourth, and fifth toes, eventually causing them to develop deformities, which can include hammer toe deformities, like you see here, where the big toe is starting to kind of undermine the second toe and cause it to pop up. So in terms of care, we talk about non-surgical and surgical options. So in terms of non-surgical options for bunions, they primarily involve modifying your shoe wear, trying to find shoes that have a wider toe box, either that or a more compliant material that has a little bit more give to it so that it can accommodate the shape of the foot. Some people also go to a custom shoe store where, and there's not many that exist anymore, but they'll have like a shoe smith who can actually stretch the material to accommodate the shape of the foot. There are also devices that are known as toe straighteners or bunion splints and toe spacers. What I will caution you on is that these do not halt the progression of the bunion. No matter how they're marketed, they are not designed to necessarily correct the deformity. Essentially what they do is they will hold the toe in a certain position that may make it less symptomatic, but the minute you take off that splint or that spacer, the big toe is going to go right back to where it wants to be. And so the misnomer here is that this can ultimately correct the bunion if you wear it long enough. That's not the case. The best case scenario is that while you're wearing it, it may make the bunion a little bit less painful. So it's very important that you be careful with how some of these devices are marketed when you look them up online. A lot of times I'll see patients who have come in who have a painful bunion and they've had a custom orthotic made for them. And once again, a custom orthotic is not going to correct your deformity. And in some cases, it may make the symptoms better, but a lot of times it can actually worsen symptoms because that orthotic takes up more space in the shoe, and therefore what's already a tight fit can become an even tighter fit. Not to mention the fact that custom orthotics are expensive. Unless you're a diabetic, insurance will not cover a custom orthotic, and they can cost upwards of $300 to $400 a pair. So if you're going to invest that amount of money, of your own money, you want to make sure that it's going to at least have a good chance of working. And so I would say that a custom orthotic is not something that, generally speaking, is going to help with a painful bunion. This is just an example. If you were to go onto Amazon and type in the word bunion, you will see all kinds of devices pop up. And just if you look, I'm going to highlight what you'll see on the top left of this screen. You'll get upwards of over 9,000 results. So there is a lot of marketing out there. There's a lot of devices that have been invented. And again, what I will tell you is that they're not going to correct the bunion. The minute you take off these devices, the bunion comes right back. The best case scenario is that they may help to reduce some of the symptoms related to the bunion. So when we talk about surgical management, what do we use to determine whether someone's a good candidate for surgery? Well, in my mind, the best indication for surgery is a painful bunion. We don't generally operate on bunions that do not hurt someone. Generally, I want a patient that has obvious discomfort, that has started to interfere with their abilities to be as active as they would like. I think that's a reasonable indication to operate and fix a bunion. Obviously, we want to try everything we can from a non-operative perspective before we go through with surgery, because obviously there's no surgery without risk. The one indication that I would argue that you want to fix a bunion where there may not necessarily be pain associated with that bunion is if the deformity becomes so pronounced that a patient starts to develop ulcers around their toes because their toes become so deformed that they rub in a shoe, and that rubbing can lead to an ulcer, because the ulcer can then lead to an infection, and that's something we definitely want to avoid. So that would be D1, and I will tell you it's very rare to see a bunion that bad where they do develop ulcerations, but it can happen. That would be the one indication, or one of the few indications in my mind, to correct a painless bunion. So there again, we're highlighting again this pain, the medial eminence that develops in the bunion, and here you can see how that bunion affects the other toes. You can see the big toe starting to ride under the second toe, and the patient starts to develop a callus over one of the knuckles of their second toe, and that can then become painful. So I will tell you that, like I said earlier, no surgery is without risk, and bunion surgery is no different. Surgery can be painful. Essentially, the way we have to correct the bunion is essentially by breaking the bone and shifting it to correct the alignment. I tell every one of my patients that prolonged swelling is very normal. It is normal for this foot to be swollen for many months afterwards, even if there's no pain. When I have a patient who is getting a bunion fixed on their right side, so that's the foot we use to drive, one of the key things that oftentimes we may not think about ahead of time is that we're not able to drive for 6 weeks afterwards. That's to allow for healing and whatnot. So that can be a big deciding factor for patients of whether they want to go through with a procedure to correct the bunion. And there are a wide number of different procedures that we have available to us to correct bunions, and the recovery time from these procedures varies tremendously. And a lot of the way we make the decision as to what procedure is best essentially comes down to the degree of deformity of the patient. And there are other factors too, but that depends upon a lot of times what we see on the x-rays. In terms of outcomes, again, I tell every patient one of the things we have to be mindful of after we correct a bunion is the tendency for it to come back or recur. Reported recurrence rates hover around 10%, but it could be even higher. We know that one of the biggest risk factors for recurrence of a bunion is the age at which you have it corrected, meaning that the younger you are when you have it corrected, the more likely it is to come back later in life. And that's really just comes down to the law of averages. One of the other big risk factors for recurrence is that the improper procedure was done. So, for instance, someone tried to do a little bit more of a less involved procedure to cut down on recovery time, but maybe that procedure wasn't the right procedure given the severity of the deformity. So it's very important that we take all these things into consideration. And I also want to talk with patients about what their expectations are from surgery. Is their expectation that they're going to get back into a 3 or 4 inch heel? Because that's a patient who ultimately may be very disappointed with their surgical outcome. And studies have shown that upwards of 40% of patients are unable to wear their shoe of choice. And that's particularly patients who are looking to get back into a high-heeled or very tight-fitting shoe, because that may not be possible even if we have a successful treatment in terms of correcting the bunion. So definitely things to think about. And I try to have this conversation with all of my patients in the office when we're talking about surgical correction for a bunion. So this slide shows 3 different x-rays from 3 different patients who have had 3 different procedures performed to correct a bunion. On the left, this is, I would argue, one of the least involved procedures. And this is for what I would call mild to moderate deformity, where you make a cut in the bone towards the end of the metatarsal and you shift it over. This is done in combination with tightening up of the joint capsule on this side of the joint, so that helps to prevent the bunion from recurring, as well as shaving down the prominence of the bone. In the middle, this was a patient who had a little bit of a more severe deformity. And so therefore we know that simply cutting the bone down here is not going to be enough. And so what we have to do, and again, there's a lot of different procedures. So the procedure I'm describing here may not be the same procedure that my partner would do, but it basically comes down to what you're most comfortable with. But for when you have a more severe deformity, you oftentimes have to cut the bone closer to the back or the start of the metatarsal here so that you can get a more pronounced correction. And this is a procedure where I make a cut in the bone and I actually wedge it open. This is a titanium plate here that has a little wedge here built in that helps to wedge the toe over. So this bone was at one point heading out in this direction. We swing it over, and again, we shave down whatever prominence is left, and we tighten up the joint capsule down here to hopefully prevent it from drifting back out to the outside of the foot. And then lastly, for some of the more severe deformities that we have, this can also be a procedure that we can do in someone who has arthritis in the middle of their foot. We actually fuse this joint here. And sorry, my cursor looks like, there we go. This joint, it looks similar to this middle x-ray, but this is slightly different because we've actually fused the joint in the middle of the foot in order to correct this deformity. And there's a number of reasons, and I'm not going to get into the nitty-gritty as to why we would have to fuse that joint, but I usually leave that. I will explain it to patients when they have to have something like this done as to why we have to have it done. But that is kind of one of the more involved procedures as far as recovery time and whatnot. And sometimes if a patient has really bad arthritis in association with their bunion, so again, we're talking more like arthritis down here, we may even fuse the joint down there. So again, I think the biggest thing with treating bunions is to have a nice conversation with the patient to find out what is holding that patient back, what are their symptoms, and then finding out, well, what are our goals with treatment? Because I think managing the expectations and managing the goals is sometimes, or the lack thereof, is sometimes one of the biggest reasons why we hear about failed treatment for bunions or why patients are frustrated. I think it's very important that we talk about the fact that the bunion could come back. And I do tell everyone, even though the bunion may come back later on in life, that doesn't mean it hurts someone. I would say a lot of times if I see a bunion that has come back, it actually does not bother them. And so for that reason, we don't do anything about it. And I always tell a patient who comes in to see me who is looking for surgical treatment for a bunion, but it doesn't hurt them, it doesn't prevent them from being as active as they would like to be, I would avoid surgery. And I'm a surgeon, so I like to operate, but that I have no problem telling that patient, I really don't think the risks of surgery are worth the reward. So next, we'll move on to discuss plantar fasciitis. So this is another very common problem that I see in the office. The plantar fascia refers to a fibrous band of tissue. It's essentially a ligament, and it's depicted by this white structure here in this picture. So it starts, this is the heel bone here, and so it starts down at the bottom of the heel, and it kind of fans out as it expands down to the toes. And this is a structure that helps in supporting the arch of the foot. So risk factors for plantar fasciitis, which is essentially an inflammation of this ligament. Risk factors can include obesity, tightness of the foot, and especially the calf musculature. And I would argue that that's probably the biggest risk factor for developing plantar fasciitis. Next, you'll see fat pad atrophy. So everyone, we all have essentially a pad of fat underneath our heel. That's very important for how we are able to get around. In some patients, and a lot of times we don't know why, they develop atrophy or essentially thinning of that fat pad. And that can really lead to a lot of problems and a lot of heel pain if it starts to thin out. We do see plantar fasciitis in patients who have severe flat foot deformities, but we also, on the flip side, see it in patients who have severely high arches. A lot of times we'll see it in patients who may have been sedentary for a period of time, and then all of a sudden they decide that they're going to be doing a lot more exercise or changing their overall level of activity, and that change in activity can precipitate the development of this problem. That's not to say that there are marathon runners who get plantar fasciitis. I see plenty of runners who develop this, and it can be quite debilitating. So chronic overuse as well as repetitive trauma are also big risk factors for developing this condition. So the symptoms of plantar fasciitis are classically pain on the bottom of the heel, and it is if you Google plantar fasciitis, you'll see stories that describe pain, particularly when a patient first wakes up in the morning. Those first few steps when they get out of bed are excruciatingly painful. It feels like a knife going up into their heel. And we refer to this as startup pain. It doesn't just happen in the morning, but for instance, if for those of us who have a desk-based job and you're sitting at your desk for a few hours and then you go to get up, it's the same phenomenon. It's essentially pain that occurs after someone's been relatively sedentary for a period of time, and then all of a sudden they start to walk around more. This can progress to the point where it has pain all the time, not just in the morning or not just when we first get up to start walking again. And this can progress to pain all throughout the day, and it can increase and get worse with activity. When we evaluate patients in the office, we do get x-rays, and about 50% of the time there's a heel spur, and that's circled here with this red circle on this x-ray. And you can see it looks like this little hook of bone coming from the underside of the heel. That is exactly where the plantar fascia originates. I will tell you that the heel spur itself is not the cause of the pain. The pain is due to inflammation of the ligament. The heel spur actually forms as a manifestation of the chronic problem. So that ligament is inflamed and it tightens up as a result of that inflammation, and that tightening causes stress and pulling on the bone. And so the bone senses that, and its response is to form more bone there to try to stabilize the problem. And so I see a lot of people come in who have been told, oh, you have to have that heel spur removed because that's what's causing the problem. And I have to tell you, that's not the issue. It's just a manifestation of a problem going on with the actual ligament itself. And studies have shown that a heel spur is present in greater than 15% of asymptomatic patients. I would argue that I think it's much higher. I think a lot more people come into my office, and incidentally, I see that they have a heel spur, but they have absolutely no pain in that area of their foot. So when we talk about treatment options for plantar fasciitis, they can go from simple to fairly involved. Simple options involve orthotic inserts, and these can be over-the-counter or custom. And remember how I mentioned when we were talking about bunions, custom orthotics are oftentimes very expensive. Unless you're diabetic, $300 to $400, and insurance is not going to cover it. So I find that an over-the-counter orthotic insert is just as good as a custom insert, and oftentimes much cheaper. Other treatment options that don't involve any surgery involve stretching, and I find this to be the most effective treatment. And there are a variety of stretches that exist for patients with plantar fasciitis. One of the best ones is depicted here in this top picture, and you notice that the patient has their leg crossed over the other leg, and what they're doing with their hand is pulling up on the toes so that they're stretching. The plantar fascia, if you look closely enough, you can actually see it right here. It's this tight band of tissue here. By pulling up on the toes, you're stretching the plantar fascia, but notice this patient's also not only pulling up on their toes, but they're pulling their foot up. So stretching is not just stretching the plantar fascia, but also, and I think most importantly, stretching their calf muscle, because 9 times out of 10, a patient who has plantar fasciitis has a very tight calf muscle. And stretching that calf muscle sometimes is all that it takes to get the patient feeling better. So you'll see various calf stretching exercises depicted in the cartoons here. One, just taking a towel and pulling up on the ball of the foot while keeping the knee straight. And then here is an exercise that you should do if you have like a banister or something to hold on to, but you basically stand on the edge of a stair with the ball of your foot and just slowly lower yourself down. So again, you're stretching the calf muscle here. Other treatment options include over-the-counter or prescription-strength anti-inflammatories. So that includes ibuprofen, Motrin, Aleve, naproxen, meloxicam is a common prescription-strength anti-inflammatory. Icing can help manage symptoms, but it's not necessarily going to help in healing anything. When patients come in who have really bad plantar fasciitis to the point where they can really hardly walk, I will oftentimes immobilize them in a boot for upwards of a month. And that helps to just quiet things down before we move to additional treatment options. Other additional treatment options can include a night splint. So that's depicted here in the top right. And essentially what that, I reserve this for patients whose symptoms are primarily present in the morning when they first wake up. And the way the night splint works is, as you can see, it's keeping the foot held upright. if you don't have something like this on, otherwise when we sleep, the foot is in a resting position, so it's pointed downwards. And what happens in that position is the plantar fascia tightens up. And then we go to take those first couple steps in the morning, and all of a sudden it's suddenly stretched out. And on a microscopic level, it tears a little bit. So the night splint helps to keep things stretched out overnight so that those first few steps in the morning are less painful. I find that physical therapy can be very helpful for this problem. And specifically, when I write a physical therapy prescription for a patient, I will ask the physical therapist to include Graston technique. Graston technique is what is depicted in this picture on the bottom right. And I tell every patient to take some time, take some Advil before they go, because it is painful to have done. And for those of you who have had it done before, for whether it's plantar fasciitis or other musculoskeletal problems, you know what I mean. And I tell everyone it's short-term pain for long-term gain. It really does help with this problem. And it involves taking these metal objects and doing a really deep massage to the area, and it stimulates this micro trauma to almost signal to the body that we need to heal this area. And so I really find that this helps a lot of patients. Again, if I have a patient who comes in who's in a lot of pain, can hardly walk, I'm going to immobilize them in a boot first, try to get their symptoms to a manageable level before we start physical therapy. Because if someone's really inflamed and really flared up, they're not going to tolerate physical therapy very well, and therefore they're not going to be able to get as much out of it as we would like. In terms of cortisone, this can be very controversial, and I really advise on the judicious use of cortisone for this problem. I see patients come in who have been injected upwards of 10, 15 times, and that's just not good. Cortisone is essentially a Band-Aid for the problem. It really doesn't heal anything. In fact, it does the opposite. And I will tell you that when you inject cortisone in this area, there's a lot of important structures, including nerves and blood vessels in that area. So you have to be very careful, because if you inadvertently injure one of those structures, it can lead to even worse pain and worse debilitation. And I really don't advise injecting any more than 2 or 3 times in a year, because the cortisone also deteriorates a lot of the surrounding tissue. And so if you keep on injecting an area, eventually that tissue is going to break down and lead to further problems. So I really am careful with who I inject. I'm not adamantly opposed to it, but I really try to do everything that we've talked about before this, before we try a cortisone injection. Other things that you'll read about that are relatively newer technologies that maybe not as tried and true as some of the other things, but have gained a lot of popularity recently, include PRP injections. So PRP is platelet-rich plasma. Essentially what this involves is you go into the office, you have some blood drawn, usually from your arm, and for about 15 to 30 minutes, they concentrate that blood and take the platelet-rich plasma from that blood, which is rich in healing factors and whatnot, and they inject that into the area where you're having pain. And in this case, it would be your plantar fascia. The issue is that most insurances do not cover this, so it can be expensive, over $1,000 per treatment, and so you're paying out of pocket, and it has variable effectiveness. So some studies have shown that it works, other studies have shown that it makes no difference. So I tell patients who ask me about it, I don't personally do it, but I have partners who do it. I tell them that, listen, you're not necessarily, it's very rare that you would get worse from it, but as long as you know that despite you having to pay potentially a lot of money for it, you have to just know that there's no guarantee that it's going to work. Other treatment options include shockwave therapy. Shockwave is what's depicted in this top right picture. It uses ultrasound waves to essentially stimulate micro trauma to the area to signal to your body to heal. This is a non-invasive procedure in that it doesn't involve a needle, it doesn't involve any incisions, but it can be painful, much like the Graston technique I talked about can be painful. And oftentimes this requires multiple treatment episodes. And once again, those insurance may not cover it. And so oftentimes patients are left to pay out of pocket for it. And again, we just have to caution a patient that, hey, there's no guarantee that this is going to work. As long as you're okay taking on that risk and still paying for it, then, in general, you're not going to necessarily get worse from it. And then finally, bone marrow concentrate. Sometimes people refer to this as BMAC. This is a little bit newer than PRP, But the issue here is that it involves an actual surgical procedure. It involves a patient undergoing anesthesia because we insert this large bore needle percutaneously into oftentimes the pelvis. So the pelvis is kind of the prominent area of your hip, very superficial, so it's easy to gain access to. And essentially we insert this large bore needle and we withdraw some of the bone marrow from the pelvic bone. And then we concentrate that down using a machine that takes about 20 minutes or so to concentrate essentially all of the stem cells and growth factors from that bone marrow. The benefit of this relative to PRP is that you get a higher concentration of stem cells. The downside is it involves surgery. It's a surgical procedure. You have to generally be under anesthesia in most cases for it. And once again, the issue comes up of insurance coverage. So a lot of times patients may have to pay out of pocket for it. I tell every patient for plantar fasciitis, we need to avoid surgery if at all possible. I will generally treat patients upwards of 1 year, or at least if they've been treated elsewhere for at least a year, and they have failed that non-operative treatment before we entertain surgery for plantar fasciitis. And the surgery generally involves a partial but not a full release of the plantar fascia. And so that's kind of depicted here. We generally will release about 50% of the thickness. This is oftentimes done in conjunction with a lengthening of the calf musculature or the Achilles tendon. Just remember, like I talked about earlier, a lot of the patients who have issues with plantar fasciitis also have issues with tight calf musculature. And so lengthening the calf musculature can really help in minimizing recurrence of this condition. And there are some surgeons across the country who are actually taking patients to the operating room and just lengthening the calf muscle, not doing anything to the plantar fascia, and they're reporting good results. There are still no guarantees with surgical release, and that's why I really caution patients that we need to avoid it if at all possible. And I have seen patients who have been operated on elsewhere who are actually worse than they were before surgery. And once you've released or done a partial release of that plantar fascia, there's really no going back. There's nothing that can really correct that. And so it's really unfortunate when you see these patients because there's not a whole lot you can do to help them, particularly from a surgical standpoint. So that's why I'm very hesitant to sign patients up for plantar fascia surgery. It really takes a lot for that to happen. And generally speaking, the good news is that 99.9% of patients will get better with non-operative management. It's just you have to be very patient. So in summary, this is a very frustrating condition for patients. It does have a tendency to come back again and again, even after one gets better. I will tell you it's just as frustrating for me to treat this condition because I wish I had a magic wand to just make it go away. We talked about that it can take upwards of a year or more to get better with any treatment, and this includes surgical treatment. And the biggest thing that I tell patients to do once we've got someone feeling better, to really keep up with your stretching exercises, and in particular your calf stretching exercises. I can't understate that enough because that will help to reduce the risk of the problem coming back. So finally, we'll talk about Achilles tendon problems, and I will repeat some of what I talked about with plantar fasciitis because a lot of times we see Achilles tendon problems arise in individuals for the same reason that we see arise with people who get plantar fasciitis. So specifically, we'll talk about tendon ruptures as well as tendinitis. So the Achilles tendon is the largest and strongest tendon in the body. If you feel down the back of your lower leg, just above your heel bone, that tight rope-like or cord-like structure is your Achilles tendon. It is the most common tendon rupture in the lower extremity, with a peak incidence in the 3rd to 5th decades of life. So essentially patients in their 20s through 40s, but that doesn't, there are certainly patients in their teenage years who can rupture, and there are certainly patients beyond their 40s who rupture their Achilles. There is as opposed to the bunions that were more common in females, Achilles tendon ruptures are more common in males. This is an example of an MRI that shows a rupture of the Achilles tendon. The Achilles tendon is usually a black, almost like cord-like structure, a rope-like structure. And you can see here's a portion of the Achilles tendon. Then there's this white area here. And then you see the black cord-like structure again. This white area is the rupture site. So that's where it essentially has snapped. And that's where the arrow is pointing. So the classic story that patients who have ruptured their Achilles tendon come in is to say that they were playing sports or doing some kind of activity and all of a sudden they feel like they were struck or hit by an object in the back of their leg. They go to turn around and there's no one there. Oftentimes patients will say they either feel and or hear a pop in their leg, and they subsequently have immediate pain localized to the Achilles tendon. One of the misnomers is that once you rupture your Achilles tendon, you can't walk. That's not true. Initially, it's going to hurt. But after, usually 1 or 2 days after the rupture, a lot of times patients' pain levels significantly decrease, and people can walk with a ruptured Achilles because there's other tendons in the leg that can help function in a similar way to the Achilles tendon. That being said, just leaving an Achilles tendon rupture alone can lead to significant weakness in the leg. And you can still move the foot up and down for the same reasons that I said that you can still walk on this. Achilles tendon ruptures can be misdiagnosed. They can be missed upwards of 20 to 25% of the time. This is exclusively a clinical diagnosis. And by that, I mean, we do not necessarily need any x-rays or an MRI to make this diagnosis. It is usually obvious enough from what the patient tells us in the office as far as how it happened and what their symptoms were, as well as their physical examination. A lot of times we can feel a palpable gap. When I say palpable, means we can feel it. There's a gap right where the tendon ruptured. In addition, when I go to bend a patient's foot up, I get a lot more what we call dorsiflexion. That's the motion of bringing the toes up towards your nose. So when you have an Achilles tendon rupture, that foot will move up a lot further than the other unaffected side. So in terms of treatment options, again, much like we talked about with the other two conditions, we kind of divide them into non-operative versus operative management. And for an Achilles rupture, non-operative management is a viable option. This does not mean that we just don't treat it. There is a tried and true method to treat an Achilles tendon rupture without surgery. And I will tell you that Achilles tendon ruptures are injuries that have been studied for years ad nauseum. And there have even been studies that have grouped prior studies together, and then they almost study them together to see if it shows anything different in terms of results. And I will tell you that the overarching theme is that studies show no difference in functional outcomes 12 months, so 1 year after the injury occurred. There is no difference in functional outcomes between patients who are treated with surgery and without surgery. Patients who are treated without surgery are generally treated in a walking boot that has wedges under the heel. And the purpose of that is to bring those ruptured tendon ends back together to allow them to scar or heal into place. So the question would come up, well, if non-operative management is just as good as surgical management at the 1 year mark, then why do we operate on these tendon ruptures? And the reason that I would tell you we do that is because the studies have shown that there is a lower re-rupture rate with surgically treated Achilles tendon injuries than there is with non-operative management. Additionally, we can usually rehabilitate those patients after surgery a little bit quicker, get them back to work quicker, get them back to sports a little bit quicker than in patients who we treat non-operatively. But I always tell patients there's no wrong answer here. And so I always involve the patient in this decision-making process, and I treat everyone the same, regardless of how athletic they are. And we make basically a group decision as to how we're going to go about treating it. I will say that surgical treatment, and I apologize if this makes anyone queasy, but there are a number of ways we can surgically treat these. There's the standard open repair, and this is an example of a patient who has ruptured their Achilles. You can see the two ends of the tendon here that have ruptured apart. So we've made an incision over that area. This on the top right is a depiction of what we've done after we've basically woven sutures through both ends. And then we tie those sutures together so that we get this as the final product and then close the wound over top of that. The one issue that comes up with surgery that obviously wouldn't come up with non-surgical treatment is the issue of wound healing complications. And that hovers around 5%. And I would tell you the majority of wound healing complications do not lead to any significant adverse effects in terms of a patient's recovery, but obviously it's a risk that's not going to be associated with non-operative management. There are also minimally invasive techniques that have been developed to treat Achilles tendon ruptures. The benefit of this is a smaller incision and, in theory, a lower rate of wound issues. I will tell you that some studies have shown that these minimally invasive techniques have led to a weaker repair, although there are just as many studies that show that there is no difference in the strength of the repair. And some studies have shown increased rates of nerve injury with these minimally invasive techniques. But at the same time, other studies have shown no difference in nerve injury. And so I would tell you that in terms of what's the right answer here, I would just go with whatever your surgeon, whoever you're seeing in the office, is most comfortable with and what they do more of, because that is the key as far as obtaining a good outcome. When we so now we'll kind of move on to Achilles tendonitis, and this will be the last entity.
Real quick, Dr. O'Neill, there was
Yes.
a question.
Sure.
How long can you go if you have a tear in the Achilles versus before you reach full rupture?
Okay. So a patient has a tear in the Achilles tendon, but it hasn't ruptured.
Correct.
I'm going to get to that with the tendonitis part of talk, because a lot of times someone who has a tear in their Achilles, a lot of times that's a patient who may have had an MRI of their Achilles, and the MRI read says that there's a tear, and I'll kind of get to that a little bit with the tendonitis part of the talk. And if I don't answer that question, we'll kind of go back over it at the end, if that's all right.
Yeah. Perfect.
So when we talk about Achilles tendonitis, it can occur in three main areas. This is what we call the myotendinous area, where the tendon starts to blend into the muscle fibers. And when we develop tendonitis or even a strain or tear up in this area, it's always managed non-operatively, non-surgical. Mid-substance, this is the most common area. This is kind of like the middle of the tendon. This is the most common area to get a rupture. But you can also get tendonitis or tendinosis there. So that's when we refer to mid-substance, it's kind of like the mid aspect of the tendon. And then there's insertional tendonitis. And this is kind of right in the back of the heel where the Achilles tendon inserts. And this, I would say, is the most common of the three forms of tendonitis that I see in the office. So we talk about risk factors. There are both extrinsic and intrinsic. Extrinsic factors include, job conditions, poor shoe wear, poor technique with regards to training or running, overuse. Intrinsic factors tend to be more increased age, postural problems such as flat foot or high arch problems, muscle or tendon deficiency. And those can all come together in the setting of repetitive trauma that induces this microscopic injury or this microscopic tearing. And that's kind of what we see on these MRIs. If you were to get an MRI of someone who has Achilles tendonitis, that radiologist is going to read it as what they call, the buzzword is interstitial tears. So that's basically, if you imagine Achilles is like a rope, an interstitial tear, and hopefully everyone can see my hands okay, an interstitial tear is like this. It's essentially a stretching or a tear on a microscopic level, but it's not an all-out rupture. And so as time goes on, if this is inadequately treated, it can lead to inadequate healing and further injury, and it becomes almost a snowball effect. And so when we refer to tendonitis, the itis is the inflammation of the tendon. You will also hear some physicians talk about tendinosis. Tendinosis refers to the more chronic manifestation of the tendonitis. Tendinosis just refers to basically a diseased tendon. And this is characterized by thickening of the tendon, degeneration. Again, that buzzword I talked about, interstitial tearing. And this can occur as a result of the tendonitis. So classically, the symptoms are pain in the back of the heel. So as opposed to plantar fasciitis, which is the bottom of the heel, this is pain in the back of the heel. And if it's mid-substance tendonitis, it's going to be more painful over the tendon itself, up here, kind of a little bit higher up. Sometimes there can be warmth and swelling in the area. The pain can be activity-related, or it can be startup, for instance, when we first get out of the bed, just like plantar fasciitis. And just like plantar fasciitis, it's often seen in patients who have very tight calf musculature. This video here is showing someone who has a very tight calf muscle. You can barely get their foot up to a 90-degree angle with the rest of their leg. Normally, you should be able to get that about 10 to 15 degrees at least above that 90-degree angle. So when we get x-rays on these patients, whereas x-rays for a rupture are not necessary, I do get x-rays for someone who has Achilles tendonitis, because a lot of times we'll see robust spur formation in the back of the heel where the Achilles inserts. Again, that spur is a manifestation of the chronic problem. Additionally, there can be an entity referred to as a Haglund's exostosis or deformity. And that's this spike of bone. This looks like a shark fin here coming off the back of the heel bone. Normally the back of the heel bone should be nice and rounded. And so some people, and this can be, genetics, people are born with the heel of this shape, this can put increased pressure. The tendon runs right here. So that puts increased pressure on the underside of the tendon. And then you imagine a shoe or something pushing on the back end, and that tendon's kind of getting smashed in between the two areas. If we were to get an MRI for someone who has Achilles tendonitis, we'll see thickening of the tendon, interstitial tears, again, that buzzword. And if we look, this is an MRI. Again, this is a view, this is kind of the side angle of someone's ankle. So their toes are pointed out to the left here, and their heel is in the back here. This black rope-like structure is the Achilles tendon. Notice how it gets thick right down here, close to where it inserts. And see this little white line in there? That's actually an interstitial tear. So again, it's a tear within the tendon itself. The tendon is still intact, but it's a tear within the tendon. And sometimes we'll see inflammation around the tendon as well on the MRI. So this is a condition that, just like plantar fasciitis, can oftentimes be successfully treated conservatively. It may be as simple as putting a little heel lift into the shoe to kind of elevate and take some tension off of the Achilles tendon. Orthotic inserts themselves are generally not as helpful as something as simple as a heel lift. For patients who are really in a lot of pain, I'll immobilize them in a boot. Once again, over-the-counter versus prescription strength anti-inflammatories can help. This is one condition where you absolutely should never let anyone ever inject your Achilles tendon with cortisone, because that can almost assuredly increase your risk for rupturing that tendon because of the effect that the cortisone can have on the tendon tissue. Stretching, just like with plantar fasciitis, can be very effective. And once again, physical therapy, including Graston technique, can be incredibly helpful for patients with this problem. And the stretching exercises are essentially the same as they are for plantar fasciitis, because again, the pathology comes down oftentimes to someone who has a very tight calf muscle. Once again, PRP, shockwave, bone marrow concentrate have been used for this problem. Again, not as commonly as some of the other things that we talked about, but they also have the same drawbacks as what we talked about for plantar fasciitis, namely that oftentimes you have to pay out of pocket and there's no guarantee that it'll work. In terms of surgical treatment, this is generally reserved for a patient who has failed everything we can offer from a non-surgical standpoint. What we do is we make an incision on the back of the leg, and we basically cut away all the diseased portion of the tendon. We remove any bone spurs, and we also shave down that prominent Haglund's deformity that I talked about earlier. You can see on the top right, this is a patient who had bad Achilles tendonitis, and this is their x-ray after surgery. You notice how we've rounded that area off in the back so that there's no bone or spikes of bone that are pushing on the tendon there. And sometimes if we have to take a significant portion of the tendon away because of how diseased it is, we have to take another tendon that in the back of the ankle that actually flexes the big toe down, and we plug it into the heel bone, and that helps to function just like the Achilles. And oftentimes that patients may get a little nervous about that, but it really comes at minimal dysfunction. You can still flex your big toe down even after having that tendon harvested and plugged into the back of your heel bone. The recovery for this surgery is a little bit more prolonged than the recovery for someone who I fix an acute rupture on, though. This, I keep patients off non-weight bearing for 4 to 6 weeks, as opposed to an Achilles rupture, where they're generally walking by the 3-week mark, of course, in a boot. And then after this period of non-weight bearing, that's followed up by about another 4 to 6 weeks of walking in a boot. And then it's followed up by extensive physical therapy, and can be a fairly extended recovery. And I tell patients who have Achilles rupture, as well as patients who have undergo treatment, surgical treatment for bad Achilles tendonitis, it can take upwards of a year to get full recovery back and full strength back. We see professional athletes who rupture their Achilles tendons, and it takes them 12 months to get back to their sports. Now, there's obviously some exceptions, but you see these athletes sometimes take a year to get back, and these are individuals who have trainers with them every hour of every day. So they have top-notch rehabilitation care, and it still takes them that long to get back. Now, granted, they're getting back to a higher level of activity than you or me in general, But it just is, and I share this with all my patients, it just serves to show that this is an injury that can take some time to recover from, but ultimately patients do make a good recovery, whether it's treatment for an Achilles rupture or treatment for bad tendonitis. So that concludes everything for this talk. I know it was a lot of information. I'm sorry it was a little bit long there. So we'll open it up for some questions, and hopefully you guys all found it useful. And this is just a little slide here, and for scheduling purposes, for those of you who may want to make an appointment, you can call this number, and you get immediate access to a scheduling representative who can walk you through, appointment availability and get you in at the soonest possible time point.
Dr. O'Neill, I may have missed this, but did you touch on neuroma at all?
I did not.
There's a couple people that asked if you could speak a little bit to that.
Yeah, I could. I'll quickly share. Neuroma is, sometimes this is pain oftentimes down by in the foot, down by the toes. Typically, I don't see it as commonly as I see these three problems, so that's why I kind of didn't touch on it. But I do see a fair amount of it. And oftentimes it's this nerve or electric shock like pain, typically worse when someone's wearing a shoe as opposed to them being barefoot. The diagnosis of a neuroma is almost 100% of the time made by physical exam alone. So to diagnose someone, I have to examine their foot, because there's a lot of structures in that area of the foot. And, they're very close together. And so it's very important that you do a good physical exam to elicit whether it is in fact a neuroma that's causing the problem versus something else. And essentially the term neuroma, if you were to Google it, it essentially means a tumor of the nerve. When we have a neuroma in the foot, it's not really a tumor. It's really just a swelling of the nerve because it's getting compressed between two other structures. And so this is something that can sometimes be successfully managed with a specialized orthotic insert. Sometimes all it takes is a cortisone injection to get it better. So that's one condition that I would consider cortisone for. But again, I would not do more than 1 or 2 injections, because again, that cortisone can really deteriorate some of the surrounding tissue. And surgery for treating a neuroma is essentially taking that nerve out. It's a very pretty quick recovery. Patients can walk on the foot pretty much right off the bat. And, by 6 weeks, they're back into their regular shoes. But we take out the nerve. So it does leave a patient permanently numb. It's oftentimes between the toes where these neuromas develop. It will leave them permanently numb between the toes. But for most patients who have a painful neuroma, being numb between the toes is a lot better than having the pain that they've dealt with. So hopefully that helps a little bit.
Yeah. Is there any exercises they could do, or do you suggest orthotics?
I usually always will start with an orthotic, which specifically will have a built-in pad that pad is designed to go right behind where the pain is, to try to offload the area in a way. In terms of exercises, the best thing I would suggest is, again, stretching the calf. I can't tell you how many patients, it's just like the hamstring muscles. Most patients are tight in their hamstrings, tight in their calf muscle. The looser you can get your calf muscle and the more stretched out you can get it, the less pressure there is on the foot down by the toes. And that can sometimes help with the neuroma. But sometimes it comes down to more so modifying your shoe wear and trying to avoid tight-fitting shoes, because the tighter the shoe is, generally when it's a neuroma, the worse the pain's going to be.
Okay, thank you. The next question is, they have hammer toes, second and third toe, fourth one is starting to turn. It's very painful. Would you recommend surgery?
I would. There are some things you can try from a non-surgical perspective. There's something called like a Boudin splint. A Boudin splint is a little pad that sits under the foot, and then it has a little strap attached to it that helps to bring the toe down. Hammer toe surgery, it all depends again on an x-ray to make sure that there's no bunion, because if there is a bunion, and it may be a subtle bunion, but if there's a bunion, you do need to correct that in order to successfully correct the hammer toes, because you have to get the big toe out of the way to bring the lesser toes down. So again, hammer toes are just like bunions. If it doesn't hurt someone, I don't generally advise getting them surgically corrected. But if they are causing pain, and that pain hasn't got better with modifying shoe wear or trying to modify activities while still being able to stay active, then I think that's a worthy indication to have them surgically treated.
Great. Next question. Why is non-weight bearing protocol longer for Achilles tendonitis versus rupture repair?
So with the Achilles tendonitis, essentially what we end up doing is we almost completely detach the Achilles tendon off of the bone. So we're completely taking it off, its attachment on the back of the heel bone, and then re-anchoring it back down. And it's that is the reason why it's longer, because we have to protect that repair a little bit better because it takes a little bit longer to heal. And the way in which we repair it may not necessarily be as strong as using all that suture that we can use to repair a mid-substance rupture. So it's essentially comes down to the fact that we have to take down the actual insertion of the Achilles tendon on the bone. And in rare cases, you do have a patient who actually ruptures off the insertion. So as opposed to rupturing in the mid-substance of the tendon actually pulls off the bone itself. And so those patients with, even though it's an acute rupture, the fact that it came off the bone and I have to reattach it to the bone, that's a longer recovery for that reason.
Okay. Next question. Is ice an effective route for plantar fasciitis or Achilles tendonitis?
It can certainly be. So I would say yes, especially when it's acutely flared up. So a lot of times with plantar fasciitis, and I didn't mention this in the talk, you'll hear about the frozen water bottle trick where you freeze a water bottle and then you just roll your foot over it. Ice can definitely help. The one thing with ice is it doesn't change the disease process. So it's not like helping things to necessarily heal. What it's doing is it's essentially making you feel better though. So it's kind of like a Band-Aid. It's helping to reduce the pain, but not necessarily inducing any specific healing response. So I generally tell patients, you can certainly ice it. There's generally no harm as long as you're doing about 20 minutes on, 20 minutes off. You're not necessarily harming anything by icing, but if you find that it's not helping at all, then you don't have to continue doing it.
Okay. Next question. Can a ganglion cyst cause pain on the bottom of a foot while walking like a knife?
Yes. So a ganglion cyst can. I will tell you that a ganglion cyst is usually a cyst, which is essentially a fluid-filled sac. Oftentimes it comes from an outpouching of joint fluid or a tendon sheath. A ganglion on the bottom of the foot is a relatively rare condition. And more oftentimes we see it around the ankle joint. But that being said, it can occur. Sometimes if you have what may be diagnosed as a ganglion cyst on the underside of the foot, you also have to be mindful of other diagnoses, namely something like a plantar fibroma, which is a thickening of the plantar fascia, and it basically manifests as a lump on the bottom of the foot. But yeah, those can definitely be painful and sometimes can be misdiagnosed. So, a lot of times the diagnosis of a ganglion cyst, you get an MRI or an ultrasound to confirm that it's a ganglion cyst as opposed to something like a plantar fibroma. Great.
Next question. Are negative heel shoes, as in earth shoes, helpful for plantar fasciitis?
They can be only because they're helping you stretch out the calf musculature and keeping it stretched out. And so I tell again, that's kind of one of those things where I tell patients, listen, there's no guarantee that they would help, but it may be worth a try, especially in someone who's tried a lot of different things and nothing seemed to work. The fact that it has that negative heel, it's allowing that calf and the Achilles to kind of stretch. And we know that the plantar fasciitis is oftentimes tied to someone who has a tight a tight calf musculature. So that negative heel can help, although usually those negative heel shoes are not super dramatic as far as how much they drop the heel. So again, it can be worth a try for someone who's tried a lot of other things and maybe that hasn't worked. But there's certainly no guarantee that it would work for sure.
Great. That was the last question. So thank you so much for taking the time to do this. Just like Dr. O'Neill said, this VIP number 610-480-6584 is a VIP number. There's extended call center hours, a patient representative that will get you right in to see Dr. O'Neill. Again, he sees patients out of Limerick and Lankenau. And before I sign off, there actually is one more question that just popped up. Let's see. Oh, maybe it's not a question. Okay, not a question. Oh, yes, it is. Cyst is from the sinus tarsi fat on MRI, and I'm unable to walk and also have a small plantar spur. He says it's a question.
And cyst is coming from the sinus tarsi? Is that what it said?
Yes.
So the sinus tarsi, that's probably coming from the subtalar joint. And again, I guess if it's causing pain on the underside of the foot, so the sinus tarsi is kind of more the outside of the foot, outside of the ankle. If the pain is more the underside of the foot, then it's most likely not related to that cyst per se. That cyst would generally cause pain on the outside of the ankle or the foot. So it may be that the MRI showed a cyst there, but that cyst may not be causing the pain on the underside of the foot. The underside of the foot pain may be due to plantar fasciitis. It could be due to, there's other things that can cause pain on the underside of the foot. But that would be something, I'd be interested in seeing the MRI and knowing exactly where on the foot that the patient is having pain. But obviously, if it's pain to the point where, we're really having difficulty walking, then I would certainly say that warrants an office visit and a little bit further workup. Usually if a patient's having pain to the point where they can hardly walk and there's no, concern for a need for, taking the patient right to surgery, I will immobilize them in a boot for upwards of 4 weeks to try to get whatever inflammation is causing that pain to quiet down. And then again, depending on the diagnosis, try to manage it with, physical therapy or some other non-operative modalities before we go down the surgical route. I hope that helps. It's a little bit tough to, without, examining the patient per se.
No, this is great. Very informative. Thank you so much. And I hope everyone has a great, healthy, happy Thanksgiving. All right.
Thank you, everyone.
Thank you, Dr. O'Neill. Take care.
Bye-bye.